All right, we're diving into Chapter 3 of our core text, and this time, it's all about organic mental disorders. Now, at its core, this is all about conditions where a real, tangible, physical problem with the brain leads directly to psychological symptoms. But, that immediately raises a really interesting question.
Right? It's the first thing you think of. Since everything we think and feel comes from the brain, isn't every single mental disorder technically organic? Well, it's a great question, but the textbook is quick to point out that this is a gross oversimplification. So let's look at what the actual clinical definition is. And here it is. The absolute keyword is demonstrable. In psychiatry, the label organic is specifically saved for disorders where there is a provable cause, a specific brain disease, an injury, some kind of dysfunction that we can actually identify and diagnose on its own. It's not that other disorders don't have a biological basis, they absolutely do. But with these, we can literally point to the source of the problem.
So, what makes a doctor think, maybe this is organic? Well, there are several big red flags. A sudden first-ever psychiatric episode, especially in an older person, is a major one. Why? Because it's just not the typical age for many other disorders to start. Also, if the person has other medical problems or neurological symptoms like seizures, that's a huge clue. And here's a big one to remember: prominent visual hallucinations. They're a very strong indicator that something physical is messing with the brain's wiring.
Okay, let's get into the two heavy hitters, starting with delirium. The best way to think of this is as a state of acute brain failure. And it's actually the most common organic mental disorder you'll find in a general hospital.
To put it really simply, just picture delirium as a sudden intense thunderstorm that rolls through the brain, causing this state of widespread confusion. It's not really a disease in itself, but more of a syndrome, a collection of symptoms that's being caused by some other underlying medical issue.
Delirium has some very distinct features. First, the onset is sudden. It happens fast. The person's consciousness becomes clouded, making them seem foggy and unable to focus. They're often disoriented, not knowing the time or where they are. And crucially, the symptoms fluctuate. This is so important. A person can seem totally clear one moment and then deeply confused the next. A totally messed up sleep-wake cycle is another classic sign.
And this brings us to a really interesting phenomenon called sundowning. You'll often see the symptoms of delirium get much worse in the evening and at night. As the light fades, the shadows get longer, and things get quieter, it can really crank up the confusion and agitation. It's a real hallmark of this condition.
Now, let's contrast that sudden thunderstorm with our second major category, dementia. This is not a sudden storm. This is a slow, gradual, chronic decline.
So yeah, if delirium is that sudden storm, the best way to think about dementia is like a slow, relentless erosion. It's this progressive process that just chips away at memory, at intellect, and even at someone's personality over a really long period of time.
The features of dementia are almost the exact opposite of delirium. The onset is insidious, meaning it's sneaky and gradual. The decline is progressive. But, and this is the most critical distinction, in dementia, consciousness is usually clear. The person is awake, they are alert, even as their cognitive functions are breaking down to the point where they can't manage their daily life.
Being able to tell the difference between delirium and dementia is such a critical skill, because their causes and their treatments are completely different. So let's put them side by side and really break it down.
These two features alone tell you so much of the story. For delirium, you've got a sudden, acute onset with a clouded consciousness. For dementia, it's a slow, insidious onset with a clear consciousness. Now let's dig into a more detailed comparison.
Okay, this table lays it all out. Look at the course. Delirium fluctuates, and this is huge. It's often reversible if you find the cause. Dementia is progressive. The sleep-wake cycle, all over the place in delirium, but usually normal in early dementia. And perception? Those visual hallucinations are very common in delirium, but in dementia, they tend to only show up late in the disease, if at all.
So, while delirium and dementia are the two big ones, the textbook also covers a few other related conditions. Let's take a quick look at a couple of them. First up is organic amnestic syndrome. The key thing here is a really severe problem with both recent and long-term memory, but other intellectual functions and consciousness are perfectly fine. A fascinating feature is something called confabulation, where the person's brain unconsciously invents stories just to fill in the gaps in their memory. The classic example you see is Wernicke-Korsakoff syndrome, which is caused by a thiamine deficiency often linked to chronic alcoholism.
And then there's organic personality disorder. This is where brain damage or disease causes a massive change in a person's fundamental character. They might become emotionally volatile, totally apathetic, or just lose all their impulse control. I mean, the person they were before the illness is just fundamentally changed.
So after going through all these definitions and comparisons, we really get to the most important question of all. Why does getting this diagnosis right matter so much?
And the answer is simple, but it's incredibly powerful. This distinction is critical because so many of the underlying causes are treatable. An infection, a vitamin deficiency, a metabolic problem. These are things that can often be corrected. If you can find and fix that root problem, you can potentially reverse the psychiatric symptoms and stop permanent brain damage.
This leads to a really logical three-step approach to managing these cases. Step 1. You investigate. You run every test you need to hunt down that underlying cause. Step 2. You treat that specific cause directly. And Step 3. You provide supportive care for the patient and their family to get them through it.
And you know, this brings us all the way back to where we started, to that one key word, demonstrable. We define an organic disorder by what we can currently prove. So that leaves us with a really provocative question, doesn't it? What about all those other disorders, the so-called functional ones like schizophrenia or major depression, where we haven't found a single demonstrable cause yet? As our understanding of the brain gets deeper and our tools get better, you have to wonder, will that line between organic and functional one day just disappear entirely?